Over the next 90 minutes, we are going to witness spine-chilling cataract surgery cases and how they are managed. So I would like to call upon the panelists up on stage, please. Dr. Shantosh, he has gone to some other hall. Dr. Kavita Rao, please. Dr. Sheetal Mahubakar, up on the stage, please. Dr. Abhijit Desai. Dr. Sachin Maholi, yes. Dr. Nivian M.
Oh, he's gone to another hall.
Okay.
There's another session.
And Dr. Piyush Kapoor, please. So we'll be starting with Dr. Kavita Rao. She's the Director, Cornea, Cataract and Refractive Services in Aditya Jyot Eye Hospital, Mumbai. She will be talking on cataract surgery with managing iris abnormalities. Over to you, Kavita.
We can ask question to the panelist. So we have a format in this session. After each presentation, we'll ask few important question to our panelist, esteemed panelist, and ask their opinion regarding this. And we can ask opinion regarding esteemed guest here to present in this hall. So over to Dr. Kavita.
Thank you, sir, and Dr. Ayan Mohanta. Thank you so much for including me in this wonderful session. So I hope I'll try and prove that I'm a tougher surgeon. I'll be showing two cases. First case is a traumatic mydriasis, as you can see on the left-hand side, history of trauma. And the second case is microcornea with iris coloboma. So this first patient, he's a 32-year-old male who presented with a shuttlecock injury in childhood. And this was the right eye, and his vision was less since childhood actually in that eye, and there was also glare. So we thought that probably there is some amblyopia component. We weren't sure about that. His vision was just about finger counting in that eye, and decided to go ahead with cataract surgery. As you can see, there is a zonular loss about 3 to 4 clock hours. So we go ahead with doing rhexis. Following that, we do a very gentle hydrodissection. The next step is to obviously insert a capsule tension ring. I feel that sometimes in my hands when I'm trying to insert the ring, the other part of the other end of the ring often just goes into the sulcus. So if you do it with a two-hand technique where you have another instrument stabilizing it, that often works. So rest of the surgery was pretty easy, uneventful. I put a 3-piece IOL in the bag, but a 1-piece could have been put as well. The next step is then to put pilocarpine in the eye after the IOL is in, and then see where the pupil is standing at and how much of the pupil damage is there and how it needs to be repaired. So what we decided to do was to do a 4th row pupilloplasty in this patient following, once the pilocarpine was used. I'll just move to the next video. So here you can see after putting pilocarpine, this is what the pupil looked like. So 4th row pupilloplasty, the way it's done is you pass it through one end of the iris. These micro grasping forceps really help a lot. You're passing a 26 gauge needle through the other end, and this is then railroaded and pulled out to the other side. This is a Prolene suture. Once you've done that, you can go in with your forceps or with a Sinski and then go and grab the distalmost, the distalmost end of the suture there. Once you pull that out, you get like a loop. Now you can cut the other end short, and the loop is then the suture is passed 4 times through that loop. This can be repeated any number of times, and it's in the end you want that the pupil obviously should be small enough. In most cases, it should cover the IOL edge if there's a lot of damage. In this case, we had to pass it 3 times, and we get a very good result. This was how it looked at the end, and you need to trim the suture probably a little shorter than what it can be seen in this case. This patient actually improved to our surprise to 6 by 12 parts, and he's very happy because he's had a vision improvement and also the glare is much better. So this is another case. This patient is a microcornea with iris coloboma. He's actually completely one-eyed because the other eye was pre-thusical. He's 28-year-old and his vision was very low, and he had this decreased vision. He also complained of glare. So, at that point we thought, well, should we do cataract surgery, or also should we address the iris part of the coloboma part in the iris? So there are a lot of techniques which have been reported in literature where they are repairing the iris coloboma, because conventionally I wasn't sure whether that would be the right thing to do because he was a one-eyed patient. Anyways, we decided to go ahead with also addressing the iris coloboma. So you do a capsulorhexis, again do a very gentle hydrodissection. Now in this case, if you see, the zonules are probably abnormal in a quite a large zone. So we had kept the Sioni ring handy, and I either use the Sioni or probably use the Ahmed segments. But I passed the CTR and then I proceeded. I thought, let me just see, and I'm sure this will be open for comments, and experts can also comment on how they could have probably done it differently or better. So once I passed the CTR, again, what I did was I got most of the nucleus in the anterior chamber because I didn't want to stress out the zonules, and I proceeded with doing the phacoemulsification. Rest of the surgery is pretty similar to the other surgery. In this case, I did go ahead with inserting the a one-piece IOL. You have to make sure, because if you're doing the phaco in the anterior chamber here, it's a good idea to use a lot of viscoat, which I have used. This is obviously it's an edited video. Now there's always difficulty in removing the cortex, especially when you've inserted a CTR, but you have to just do it slow and gentle and patient, and I think it's not so difficult. And after you've got all your cortex, you go ahead with inserting the IOL. Now at the end of insertion of the IOL, I found that the IOL complex looked pretty stable. So I then decided to go ahead with just addressing the iris coloboma and not go for inserting either a segment, or probably it could have been done differently where that could have been done. So then after the IOL is in the bag, I decided to go ahead with addressing the coloboma part. That was pretty similar, just to a fourth row pupilloplasty again after inserting pilocarpine. So since this was a one-eyed patient, again, like I said, I wasn't really sure whether this should be done, but that's open to discussion. But eventually this is done, and it's just like the previous case. If you see, when you pull it, you get a nice round pupil, and this was repeated again 3 times. And this is what you get in the end. Patient really is a very, very happy and satisfied patient. His vision unbelievably has improved to 6/6 unaided. So probably maybe because reducing the pupil size, and he's very happy. So thank you so much.
Both the cases are excellently managed. So I have a few questions to be asked to our panelists. How many of you preferred ID's hook, a capsular hook to stabilize back, or you prefer to go CTR first, or many of us prefer to put capsular hook first, then capsular tension ring. How many of you prefer to give similar situation would prefer to CTR first or put
In fact,
capsular hook?
in fact, I was just going to make a comment after she finishes it. I think I would prefer capsular hook because it makes the surgery easier, because sometimes when you put the CTR first, cortical removal becomes very, very difficult. Plus, instead of this CTR, the capsular hook will give you much more stability than just a plain CTR and not a Sioni CTR. So I think I prefer that more.
Okay, Dr. Kobita, when you prefer, if any criteria of your surgery or area of subluxation, you preferred CTR or capsular hook?
Sir, if the cataract was much denser and it was more brunescent, I would have probably preferred to use the hook, because at that point then I would have not done it in the anterior chamber. like, here if you see, I've prolapsed the nucleus, most of it, and I've done the phaco.
Because
So
you
if-
extracapsular phacoemulsification.
Correct. So if it was denser and it was harder cataract and more area of zonular dialysis, then I would have probably gone ahead with what Dr. Sheetal has recommended. But this case I felt, and cortical removal, I know like what she said, in fact, I did mention it is a little more difficult when it's CTR, but if you do it slowly and patiently, you can remove all the cortex. You just need to be
Another point here is the CTR, the normal CTR gives you just a horizontal stability. When you use a capsular hook, it will give you a vertical stability also. It's not only the cortical
See,
removal.
capsular hook actually stabilize the capsular back in anterior posteriorly, and CTR stabilize the back horizontally. So if you put the CTR and capsular hook both, you can stabilize back better than the only one CTR or capsular hook. So in these cases, I think the subluxation area was not very large. So Dr. Kavita managed well with CTR also. Many I've seen many of the surgeons prefer CTR first. Even though I prefer to put capsular hook any case of subluxation or capsular jonular weakness. So definitely the case is ultimately managed very well. And one thing I just asked to Dr. Rovijit, are you prefer to repair suture in all cases of coloboma?
No,
Because there is a one study also there, because that capsular deficient area actually overlay over the deficient of the choroidal and pigment cone cell deficient. So there is less amount of glare if there is iris defect, but definitely there is a age effect of the IOL that can create some kind of glare. So over to Dr.
I would prefer to do it if there's a big defect, definitely.
Big defect. Okay.
Yeah. So if it's more covering more than at least 2 to 3 clock hours, it's definitely good to do a pupilloplasty. And one more thing you can actually plan in these kind of cases is to put in a segment and use a iris hook for that MH segment to stabilize the bag instead of the capsular hook, and use the same segment later on to give the support out there.
Yes.
So that also works very well.
Okay.
No, I completely agree with Abhijit. In fact, we had kept a segment ready, but like I mentioned, in this case, I'm sure in other cases that's a very valid point and suggestion. In this case, because I felt that the IOL bag complex was very well centered, I didn't want to go ahead and do that. And also another thing, there was definitely apprehension in suturing the coloboma, because we have so much of literature which also shows that this patient has been used to eccentric viewing, so we don't know whether we are going to affect his quality of vision. That's why I said I was pleasantly surprised when he's actually 6'6" unaided, and so we just need to change. It's always an evolving practice. I think change
So-
is the only constant probably.
The last question to Dr. Kavita. Do you prefer Sioni ring or combination of CTR or Ahmed segment in case of subluxation in more than 180? So we have to fix the capsular bag with the sclera. So in that case, do you prefer Sioni ring or CTR with CTS or Ahmed segment?
So I think I've used both, sir, and I personally feel, but I find it easier to use the segments with the CTR.
So most of the surgeon actually preferred CTR with CTS segment because it
Yeah.
is basically the maneuver is more easy
Easier.
than to maneuver the Sioni ring.
Yes.
Can I
Yes.
ask one last question?
Last question.
So what is your preferred suture material for fixing the CTS or Sioni?
So the ninoproline, sir.
Have you used Gore-Tex?
I haven't used Cortex, sir.
Anyone of the panelists use Gore-Tex? What is your experience?
Yeah.
For the procedure point of view, it's not very different, but Gore-Tex is mainly for
Yeah,
the...
I mean for the post-operative period, is there any reaction or any kind of?
No, none, sir.
But in my
Now
experience,
Gore-Tex also available in India. Previously,
Yes, it
3-4
is
years
available.
back, it is not available. Now Gore-Tex is available. I think one distributor from Mumbai also he give the we purchase the Gore-Tex from the distributor from Mumbai. Yeah, yeah. Thank you, Dr. Kavita. It's
Thank
an
you.
excellent presentation.
Thank you, sir.
And next speaker.
So our next speaker is Dr. Sheetal Mahubakar. She is the Medical Director of SM Eye Institute, Ahmedabad, and Visiting Consultant Cataract, Cornea and Refractive Surgery, Retina Foundation, Ahmedabad. She will be dealing on any complicated scenario arising when operating a Brunison cataract.
Just put it, no? Okay. At the outset, thank you very much, sir, for having me in this session. One might want to put on the other side. That is a different one. Okay. The topic was given to me for Brunison cataract and complications arise during the Brunison cataract. So I'm going to present 3 cases. I'll start with my first one. So this, as you can see, it is a very, very hard cataract, brown cataract. For such cataract, I always prefer to stain it whether the glow is there or not. And the preference is to have a slightly bigger rhexis so that it doesn't cause any zonular stress. So once you're done with the rhexis, what I prefer is to do the hydrodissection and make sure that the nucleus is rotating. My personal choice for such cataract is stop and chop, but some people do prefer chop also, but for me in my hands direct chop doesn't work very well, so I like to make some partial groove and then go ahead with the chopping. But this cataract, when I was seeing it, it was just not breaking, it was very, very leathery. So I was just trying to chop this cataract, and eventually I can make some amount of chopping and cracking of the nucleus. And but the central posterior plate was still pretty intact and I was not able to crack it, so I just start phacoemulsifying and debulking the nucleus and decide to keep this posterior plate as it was and take care of it later on rather than using unnecessary energy. Again, the most important thing is while doing such this thing, because you use lot of energy, it is important to put visco material in between, which you had noticed just few seconds back that I had stopped it and used the viscoelastic. I prefer something like a viscoat which coats the endothelium pretty well. And once this is done, your zonules are fine, you can just go ahead with your normal lens. Now this has caused a little bit of wound burn, so I prefer giving a suture for such cases with such wounds. Now this is another case. The initial portion is a little black and white. So this is again a hard cataract where the rhexis, I do it, as I said already, the rhexis will be slightly on a bigger side. Yeah. So here there was a phacodonesis, so I decide I generally prefer anything, especially in the hard cataract, if little bit of zonular weakness is also there, I prefer using capsular hooks, 4 capsular hooks, which will stabilize my back properly. So it is very easy for me to go ahead rather than worry that, okay, I may cause problem or may increase the zonular weakness. And again, as you can see in the previous case, the stop and chop is my method of doing such cases. In this particular case, the whole crack happens and there are these 4 pieces which I make eventually, and those 4 pieces are phacoemulsified. The capsular hook sometimes, because this pupil was also, there were posterior synechia, pupil was not dilating well, it acts both as iris hooks as well as the capsular hooks. Now one can use iris hooks also to stretch the capsule, but there is always a danger because the iris hooks are pointed tips and the capsular hooks have blunt tips, so it does not damage your capsule. So again, for all the cases, because these are edited videos, every time, almost many times I come out and push with the second instrument, I take out and push visco inside to protect the endothelium. So again, there was no zonular dialysis, there was just a zonular weakness, so I put CTR and IOLs put inside. Although this particular case did not have wound burn, I still prefer in such cases to give suture, but one can do without the suture in this particular case. And I will go ahead with my last case. So this was a case post vitrectomy, post silicone oil. As you could see, there was emulsified oil, and I released the posterior synec and start doing the rexis. When I was doing the rexis, the anterior capsule appeared very fragile, very thin, but I just went ahead and decide to complete my rexis. Once I complete my rexis, although it was small, I thought that I will increase it later on, and I decided to go ahead with my hydrodissection and realized that I could not do hydrodissection because the rexis was still not happened and there is a fibrous anterior capsule. I tried to nudge it with lot of instruments, with the needle, with the knife, but nothing happened, and eventually I can make some small opening, and I cut the capsule and tried to proceed with this particular thing, but I could not continue because it was fibrous and I could not pull it, and I was just causing zonular weakness. So what I decided is made extra side ports and actually made the rexis, or made the opening in the anterior capsule with the micro scissors. And after that, the cataract was more or less like any hard cataract, leathery cataract. At some point, because the opening was small, I realized that, okay, I need to increase it. So I again went with the micro scissors, increased the opening in the anterior capsule, and went ahead with the remaining phacoemulsification. So basically, one has to remember that in hard cataract, they are there in the eyes for very long time. So plus the hard cataracts are very, very common because we do a lot of these post vitrectomized cataracts. These cataracts are also very hard. You generally have a lot of posterior synec, and this case was my first case where actually I had this kind of a thing, that I performed one rexis and there was still the anterior fibrous capsule below it. Thank you so much. I think I have some tips for the beginners especially, is basically evaluate every case properly for zonular weakness and dialysis. If there is a zonular weakness, use your capsular hooks, keep your CTRs ready, stay in the capsule every time because it makes your things easier. Use the soft shell technique for such cases because endothelium can go for a toss otherwise. Visco insertion in between the phacoemulsification. Always keep 3-piece IOL ready in case of rent. You can put it in the sulcus. If need arises, be prepared to convert it to SICS or ECC, whichever is comfortable for you, and keep the anterior vitrectomy ready, and always counsel patient about the nature of the cataract and the additional procedures may require. Thank you so much.
Thank you, Dr. Sheetal. So, one question. Why exactly do you think that wound burn had happened in your first case?
Sorry, wound burn?
Yeah.
Many a times what I have noticed, sir, in hard cataract, sometimes you want to be, at least that happens in my hands, I think, is I sometimes lift the probe up. I think that is the thing which had happened over there.
One thing I would like to mention over here is, when you are operating a hard cataract, your natural tendency is to put in more viscoelastic in the anterior chamber. And when you are entering the anterior chamber with your phaco probe, be in foot position 2 for some time so that the circulation around the tip happens, and then proceed with the phaco energy. Otherwise, if the tip gets blocked with the visco and you are you're into foot position 3 and putting in energy, that energy is going to cause the wound burn as well as endothelial damage.
I generally do that, sir. I do aspirate the visco
Yes.
most
so that's
of the
a very
times.
important point I think you should include in your list.
Yeah.
Yeah, the first case was really tough because it has a coloboma. It's a coloboma with the Brunosen cataract. So whenever there's a coloboma, and even in a normal size, the coloboma has a 3-4 issue.
The last case did not have, none of the cases had coloboma.
The first case is shown the coloboma.
Sorry?
First case probably there is a capsular defect. Can you show this video again? That's the first case looks like a coloboma with the Brunosen cataract, but there is a no zonular problem, other problem, but it's looks like a coloboma.
Okay, I'll just repeat it.
Video first one.
I did not notice.
Yeah, this is looks.
Oh, yeah,
this is a coloboma. So coloboma has a 3-4 issue. One is a hard cataract. Even those hardness looks like it's a more harder than it looks. The second issue is the smaller corneal size. In that case, it is not small. It is okay. Third case, it has a fragile capsule in the colobomatous area. In that case, I think the capsule elasticities was absolutely fine.
Yes.
And definitely AC is shallow. But in this really hard cataract,
Yes, it was very hard.
really hard cataract, and you manage so well. So, but if given me another chance to do this case, and I would prefer to put more time to sculpt more in this particular case. Any panelist, anyone?
Yes,
Generally, a
definitely. I would
four-quadrant
really
split,
go.
Yeah, matlab, I also would prefer a 4-quadrant split in it, where we do the maximum debulking in the bag, and so that there is not much of energy or the turbulence of the pieces like to chop and all. So as you said that it will be more to sculpt, it will be always a better technique. The second thing I wanted to specify, like we have been discussing about colobomas in the previous case also, previous speaker's case also. In coloboma, generally the zonules are deficient in that area. They are
Yeah,
not weak. So we need not worry about any kind of a subluxation, or like inserting a CTR is not a must in those cases because of the deficiency. Even if we are putting a CTR, it does not pull back the capsule out over there. So I personally in my hands never felt a much of an advantage in putting a CTR in the coloboma cases.
So do you prefer to put the haptic over there of the lens?
A segment of a, like later on it is to okay to cover that area, that is fine, but that again it would be depending upon the coloboma in totality. Like if, as you were saying, that there are, if the already there is a retinal coloboma also present, then the patient has been living with that kind of a scenario, and adding on, especially in a one-eyed patient and those stuffs, like too much of a procedure sometimes may become more troublesome. And retina evaluation later with a segment out over there, if an RD or something occurs, can be more tougher rather than preventing any kind of a photophobia from that area.
Yeah, this is another point. I mean, if not putting sutures in in the iris defect,
Never.
If a retina-
I personally would never actually
if a
do
retina
it.
surgery has to be done, then the
Then of
surgeon will
course,
be
because
Also, I
these
think there
eyes
is
are
enough literature available which does not add anything by doing the iris
Exactly,
repair in the
exactly.
coloboma
That's
area.
yeah.
So in fact, lot of us were doing it, which have left doing it because it is not giving any additional value to the whole.
Exactly.
rather it can give harm. It can actually be a
Produce harm.
troublemaking procedure for the patient.
Sheetal, which machine do you use for the cases?
Actually, we have.
It's a Centurion machine, but the tip is mini flare tip, I think.
Yeah,
It is not a balance tip.
It's Constellation, sir. Actually,
The Constellation,
which
whatever.
yes.
It's a mini flare tip, not the balance tip.
Was the intelligent phaco on?
Yes, for such cases, I generally do it.
So maybe it's a good idea in these cases whenever you're sculpting to add a longitudinal power to it.
Yeah, the intelligent
only
phaco,
torsional.
Yes. I generally add
So
it because
many-
only with the
wound burns-
torsional it's very difficult
the
to
wound
sculpt.
burns in these hard cataracts is because of the occlusion of the tip, and the energy is being used against the occlusion, and it goes off eventually, but you don't realize that you're using on an empty thing. So
Right.
that's why probably you got a wound burn there.
Actually, there is this tip is not very good for, say, there's a in between there is a blockage, and some doctors, even Dr. Monto is in this case, if we used torsional, some use some kind of IP during the sculpting also. So it is a good idea to use, but if you have access to balance tip, I don't think you can use balance tip even in Constellation machine. They will give they don't give it, but if you can manage them, you can use but the balance tip can fit this handpiece very
Okay,
easily.
okay.
So given this case, sculpting is much better, but even these tip has a poor holding capacity.
Capacity.
So compared to another, this is so it looks
For
like,
direct
but
chop, it's a problem.
it's a really tough case, and the
Thank you
first
so
one is a
much, sir.
tough case, and I will discuss regarding the third case also. The third case, it's not very common. It is splitting of the anti-capsule. It's not very common. Some kind we miss. This is the actual not capsular rexis. Then we have to cut the rexis. You did the all the cases nicely, so nicely.
silicone
Actually,
was
even
removed
puncturing
in
that was very tough. I must have spent hell lot of time actually because it's an edited case. And
Was
sorry,
the
sir?
silicone oil removed in the third case?
Yes,
It was
yes.
removed.
This was post SOR.
Then you have to
Why
go
didn't you
slow.
put a
I mean, use
malleable
less.
ring or any pupil expander during that surgery?
I should have used it because I think that time I was so harrowed because I did not expect what was happening, and I think the good idea over there was to put, because the pupil was not very big, so good idea
But
was to
second
use
case,
the iris
using
hooks.
the capsular hook, holding the capsular rexis as well as the iris pupillary margin. That's a very good idea.
Yes,
And that if you suspect any kind of jonular pathology and with the small pupil, it are better to use capsular hook, which can hold both iris margin, pupillary margin, and the capsule margin.
Yes, sir.
So it's a very good idea. It's a very good technique. Thank you, Dr. Shital, for
Thank you so much.
wonderful presentation.
Thank you so
We
much,
now
sir.
move on to our next case. Will be presented by Dr. Abhijit Desai. He is from Soham Eye Care Center, Mumbai. He likes to innovate. Concrete is the latest indulging. I asked him what is concrete. So he
I have
says that-
seen some of the photograph of the concrete, and
he-
will invite him for the next year for a special talk in the Life Beyond Ophthalmology.
Yeah. So he makes concrete furnitures.
Yeah, made so many concrete furniture and lampshade.
We'll be talking on subluxated cataract more than 180 degrees.
Fine. Screen यहाँ पे था. Setting is on the this one. 2 minutes. Thank you, Dr. Ayan, Dr. Arup, for having me over for this session. Lot of talk going on subluxation, so I'll add my bit to it. So here we are looking at least around 6 to 7 clock hours of subluxation in a traumatic cataract. This iris defect is superior, and you can see that it's tough to do a rexis in these kind of cases, and it's good to use a very good dispersive viscoelastic which compresses the capsule and maintains the space. And it's good to go on adding the viscoelastic every now and then, even during the rexis. I prefer to use the hooks first for this one and assess my zonular instability towards the end of the case or during the case, and then take a call about the CTR or when to put it. Now, this patient was already operated for RD surgery and he has a silicone oil already behind. And then you do a multiple quadrant hydrodissection to loosen out the subincisional nucleus, and that's how you would get the entire nucleus out during your this. It's a good idea to use irrigation aspiration in softer cases, softer cataracts, to actually loosen out that area, and then use the phacoemulsification again. We go on putting the viscoelastic so that it doesn't allow the chamber to be shallow. Now here you can see that there is one more subluxation just opposite to what I have already seen. So that means I have two areas of subluxation. So my plan was actually to do a segment there. So I now decide, okay, now I have to give 2-point fixation out here. So I decide to use a double Sioni ring here. I have marked out my 3.3 with the template, and I'm going to be using the Gore-Tex out here on a 26 gauge needle. So what we usually do is make a incision in the sclera so that the Gore-Tex suture is accommodated into the incision itself. And you pull out this particular thread out. And that free thread goes in through one of the rings, eyelets of the Sioni, which is going to remain on your left hand side. And then you make a lasso out here and pull out that loop. And using that lasso, I'm going to get the free end of the suture which is gone in the eyelet. So here you have to have your orientation right. You need to keep that eyelet which is above the plane of the rhexis in mind, and accordingly put in those particular left or right according to that. And now once that loop is, you have to keep holding the free end and then pull it out. So getting it entangled is a problem. So you always have to be careful so that the entire ring is free at all times. And that gets a loop out. And part of it, the loop is through one of the eyelets of the Sioni. Just see to it that you have enough purchase on the outside for the suturing later on. And the same thing you do it exactly at 180 degrees diametrically opposite area. A good thing about high density silicone oil is even if it tends to come up, it can be held behind by a good intraocular pressure built up in the anterior chamber. So it doesn't tend to give you a hyperoleon as often as the low density silicone oil. So the Sioni doesn't go through a 2.8, so it requires a slightly bigger wound compared to the segment. So you need to extend your wound sometimes. Now here I'm trying to put in, and it is not going in. At that time you can increase the wound using a side port incision rather than using a keratome. So that's how I would increase the incision, with just a small nick out there. So once your left side eyelet is in, I'm going to pull out the loops out there so that it doesn't any longer interfere with my vision. And I'm left with only the one on the right hand side. Now here you can use a Sinskey hook, you can use a micro grasping forceps, you can use multiple instruments to get that thing exactly aligned to the ports which are 180 degrees diametrically opposite. So a double-handed technique decreases the stress on the zonules. But here you have to understand that with the silicone oil out there, there is nothing behind to give you enough support for these kind of maneuvers. So you have to go on filling the chamber with dispersive viscoelastic and go on maintaining the pressure in the eye. So the eyelet goes over the rhexis on both the sides. And again, when you're pulling out the loops, you have to be careful about the loop not entangling into the loop itself. There you can see the part of the loop is gone around the Sioni segment. Now you just have to pull it over and then allow it to get the suture done. Suturing the Gore-Tex, you need to be very careful. It is not like suturing Prolene. So the first knot has to be slightly loose, and then you tighten the other second knot over it. To center the rexes, you need to do both the knots on either side first, and then do the second knots on both the sides, so that your rexes is well centered, and that helps you center the IOL as well. So if you see post-op, these knots which you see bumped up usually flatten out with period, and by the end of 3 to 4 weeks, you would not see them at all, though there would be some amount of congestion there till the time the Gore-Tex becomes a part of the tissue out there. That's the IOL which is put in the bag. Whatever silicone oil comes in the anterior chamber can be removed safely. I tend to take a small 8-0 suture over the knots of the Gore-Tex so that they don't slip, and then just tie the conjunctival periotomy. Thank you.
Excellent case. Really, it looks like to handle more difficult to handle the suture rather than the subluxation. Looks like really, and the lasso techniques. It's an innovation by Dr. She, and she got the ACRS Flame Award in 2018, I think, for this lasso. It's a very good technique, but do you think you can manage without lasso technique? You can manage with the forceps, micro forceps.
As in?
It's you just handling with the lasso.
Yeah.
So instead of using the lasso, can you use the
micro forceps would have a larger
larger
entry. The entry would be two big things. So, but you can do it, but you will take to take it further apart. I had seen one surgeon do it and then rotate the knot inside. So that can be done.
I was just wondering, Dr. Abhijit, instead of doing any of these things, can we just a thought, can we just not give the knot over there at the hook only, like, and just have one thread? Will it still give a good stability?
So even though we say that this is biocompatible, the knot is irregular and the iris is going to rub over it. So that's not such a good idea. That's why I don't even like putting it through the sclerostomy inside, because you don't know what tissue you're going to be irritating. So the knot remaining outside is a better option rather than going inside and we not knowing what's happening with the knot.
Many of the surgeons would have preferred a glued IOL in this case. So what's your take on it?
Glued IOL is not supposed to be glued. That 3-piece IOL is of a 13 millimeter length and it's supposed to fit the sulcus and not gotten out. So if you want to put in a IOL, a scleral tuck IOL would be a better option.
This is a definitely better option than glued IOL. Because
and in case you're removing that in a silicone oil, if I'm going to be removing off the bag, I'm making it more much more unstable for future then. So this is already operated eye for a detachment, and that's what we are handling here.
Just want to highlight this point. The lasso technique is better than the using forceps, because this suture has a property, whenever you touch, press, it becomes flattened.
Yes.
And then it is very difficult to pull with the
it's
forceps.
Even difficult to cut the suture.
It's a round, but whenever you press any place, it becomes absolutely flat.
Compressed.
So compressed. So it's very difficult to handle with the forceps. Lasso technique definitely is a better option.
And the suture is well handled when it is dry. The moment it becomes wet, again it becomes difficult to handle.
Yes.
No, to just a comment on what Sir asked is, I don't think even if there is a silicone oil and if the retina surgeon is planning to take it out, that's a bad idea to do, take out the whole thing and do something like a SFIOL by whichever technique one prefers, because that is not going to cause any problem as such to the retina per se. But I think this subluxation was the way he managed when you can keep
That's
the back.
excellently managed.
It is
Absolutely.
always better
Absolutely.
to do that. Yeah.
So, Ovijit, do you prefer the different technique as shown by Kanavara? This is a combination of Yamini technique. So, using the 50 Ponil make a bulb, and then it looks much easier and faster. Any of the panelists of the using Kanavara technique in this case?
I have tried that once, but it didn't work in my hands, so I don't know.
So again, the whole it's a young
It's a,
patient.
if you try this Kanavara technique,
I have done it in elderly patients. The dumbbell technique, you mean?
Yeah,
with the
yeah.
50 proline. So I have done it in elderly patient. It works wonderful. But as of now, at the time I had done it, it was available only on a PMMA.
Yeah.
So the foldable with the hole in the haptics were not available. So you can't do it through a smaller incision. This
No,
is
no,
a
same thing. If you use a Sioni ring fixation with a Kanavara,
I am
making a
against
bulb.
using proline.
I never use this.
No, I am now against using
Okay.
proline after seeing so many patients of degenerated proline and the back complex going down. I would
Because
rather go with
that's
your
50 Polin.
That's a
Hopefully,
thicker
that will stay
Yes,
much
That's
longer
a thicker
time.
I
proline,
think the
60.
50 prolin is not
60.
should not be an issue with
60.
the degradation.
60. Okay, wonderful case, Dr. Ovijit.
Thank you.
So our next presenter will be Dr. Sachin Mahuli. He is a vitreoretinal surgeon, director of Netrodarshan Super Speciality, chairman Netro Research Foundation, Belgaum, head of vitreoretina surgeon, Vision Retina Clinic, MAP USA, Goa, Mapusa, Goa, sorry. Fellow vitreoretina, Shankarnetala, Chennai. His area of interest is diabetic retinopathy, ROP, and AMD. He will be talking on posterior polar cataract.
Very good afternoon, everyone. So, it's okay. So these are the special type of cataracts usually occurring in young patients. Usually you could see PPCs in more congenital form. There could be a family history. 60 to 70%, 60 to 80% are usually bilateral. If you see the incidence, it's around 3 to 5 cataracts per 1000 cataract. So why are these important is we need to understand there's a very strong adhesion of the opacity to the weak capsule behind. So you have a high risk of PC defect developing during the surgery. So the chance varies between 4 to 40% that you'll have an intraoperative PC rupture. It may or may not, but certain procedures are very important. Preoperative counseling of such cases is very, very crucial. Whenever you see a PPC on, in the OPD, you need to tell them the chance of nucleus drop, need for a VR intervention, delayed surgical procedure, need for visual recovery to be delayed, and they could be having a pre-existing amblyopia, which we need to understand. So what are the surgical techniques? How does it differ? Is like mainly with the hydro procedures, you need to be very careful. You need to send a small pocket of fluid. It should not be very vigorous hydro, because there is a deficient area which you have to handle with very careful. Uh, Per se, dissection is considered contraindicated, though you can still do it carefully when you are aware of the things. Nucleus rotation to be avoided as much as possible. Avoid excessive decompression when you are doing with the needle after the hydrodissection. So this is a video of PPC, which was a soft cataract, uneventful surgery. Once you complete the rhexis, you can see. So this case I wanted to show because a careful hydro was done so that we could leave the piece behind. always you try to remove the peripheral nucleus first and then go for the central nucleus. This what you are seeing now is just the nucleus is out with the, it was very soft. So now what you are seeing is the epinucleus ball which is attached to the central defect. So go from periphery, bring it to the center, and the last centerpiece should be removed last. Because even if there is a defect, most of the cortex is out, and then you are safe enough to put a lens in the bag after doing entry-vitrectomy. In this case, there was no PC rupture. It was just a thin PC out there and went off uneventfully. In cases of mature cataract, finding out a PPC will be very difficult. So you need to rely on certain signs like this one. You can see a pupillary snap sign which says that the PC is given away. So either see that suddenly you will see the pupil coming down. So these are the signs which you have to be very carefully visualizing it during the surgery so that you can manage them accordingly. The nucleus was delivered out, a large section was done, and it was delivered out, and lens was put in the sulcus. This is one more case. Sorry, what? No. Yeah, I stopped. I'm playing over. So, क्या हुआ? I think this it stopped. I think ये play करना है.
Setting open.
Hmm?
Setting. No, sir.
Initially, I prefer to do a hydrodelineation. After removing the endonucleus part, when the epinucleus sheet is there, that time I like to do the visco dissection. So it lifts up the epinucleus. So that time it is easier to remove or you can use the phaco 3 mode also in the phaco probe to remove the epinucleus.
If it is grade 2 cataract, you can actually dissect mechanically also with Sinski hook. And there is a concept of inside-out hydro procedure which Dr. Basavda always tells in the conferences. Don't do anything. Start phaco, so the fluid wave passes when you make a groove. You want to add in?
While we are going, I saw a very interesting technique by Dr. Haldipurkar yesterday, what he showed. So he uses the phaco to do the trench, front trench, and the same phaco for the horizontal trench without rotating, divides those, and then he uses the Sinski hook to get those pieces in the center and eat them. Without any...
Scaled. लेकिन मैं वीडियो खोलूंगा कैसे उसमें? Okay. Okay, this is the last video. Sorry for the technical glitch in between. This case actually, I just wanted to show you. It was managed a little differently. After the hydro procedures, you can see when I entered with the phaco probe, you can see suddenly the nucleus tilting there. As soon as the infusion was on. So what I did suddenly was change the phaco parameters to a very low flow. So you can see that nucleus, it almost dropped. So luckily there was no vitreous coming in the anterior chamber. So I changed the parameters suddenly and tried to remove as much as nucleus I could. If it had dropped, it would have been easier for me because I am a vitreoretinal surgeon. I don't need any this thing. But still, I tried to remove most of the nuclear material with the phaco probe itself because there was no vitreous. See, these young patients, the intrahyaloid is very taut and vitreous doesn't come immediately. So most of the nuclear material was removed with the phaco probe itself. So and hydro was done, and it was brought partially into the anterior chamber. Then I started using the vitreous cutter because the vitreous had come already from the rent of the PPC. So a vitrectomy was done initially before I could manage the nucleus. Once the vitrectomy was complete, the whole nucleus was dissected and cut with the cutter itself. So after most of the nucleus was removed with the cutter, anterior vitrectomy was done, cortical wash was done with the cutter, and a 3-piece IOL was injected in the sulcus. So basically, I did not have to go past plana in this case. So just being aware of the situations, you can prevent surgical intervention which can be more extensive. So a good vitrectomy was done, and once the vitrectomy, you can see most of the cortex was aspirated and removed with the cutter itself. Cutter works like a very good bimanual tool to remove most of the cortex. So this is a three-piece lens which will be injecting inside. So after you center the lens quite well, you can just do a whisker wash and remove it. So PPC is a special condition wherein you need to be aware of most of the things, so you'll be able to manage most of the complications. Thank you.
Just a question, at what stage did the rupture occur?
Sorry?
What stage did the rupture
No, I had a doubt, the last video which I had a doubt during hydro, but when I went to the probe, it just flipped out.
So that means irrigation pressure?
Yes. So afterwards, I changed the settings of the irrigation pressure with the very low parameters. Just removed the nucleus matter as much as I could do with the probe. Then I used the cutter itself because the vitreous started coming from the PC rupture which was there. It's a soft cataract, so it comes very well with the cutter. I mean, the cut rate should be very low, suction should be high to manage the nucleus.
So any of our panelists want to comment in this case? Yes.
A short, quick comment because we are
Sachin, good
running short of
surgery.
time.
Excellent. You're a very good surgeon, but I don't know how you managed to put a 3-piece lens in that smaller pupil in the sulcus. I would actually put in a dilating agent again and visualize the capsule and then put in the 3-piece rather than, you're a retinal surgeon, I forget, sorry. But I would do it that way. And it's heartening to see the retinal surgeon do anterior vitrectomy from the side ports.
Yes.
But it's a good take-home message. Actually, you should dilate, and we have phenocaine or similar agents
Yes,
that you
yes.
can put.
Yes.
And
Secondly,
yeah.
while
On table, I could see the support well, so I just managed to slip it in.
Hello.
The problem is you need to.
Hello.
Yes, sir.
Can I ask one question?
This is
Please take the mic, just so that this mic, so that every one of the audience can
I'm
listen to
asking one very fundamental
You
question.
need to see there and operate the microscope.
It is like an undergraduate question. I have done a lot of cataract survey with the help of optometrists. I have done greatest ophthalmic survey in India. But our students are missing this posterior polar cataract, posterior subcapsular cataract, all these things. Which are the simple ways to diagnose these things? I adopted 4 methods. One is a dilatation of pupil, another is refraction mirror, another is slit lamp, another is autorefractometer. Is there any other methods which can be easily diagnosed? Diagnosis of posterior polar cataract or posterior subcapsular cataract, which can be done by in cataract survey. diagnosis of anterior polar cataract and posterior subcapsular cataract, which should be useful in a cataract survey, a blindness survey by optometrist. I had 4 methods. One is dilatation of pupil, another is slit lamp, another is using refraction mirror, another is autorefractometer. Is there any other methods which can be adapted for this procedure?
Sir,
You
we
can
will
actually
take
do
up
an
the-
anterior segment OCT.
Okay.
No, he's saying that very simply. I mean, an optometrist can diagnose like that. So we can discuss it later on after our session
Yes.
is over. So our next speaker is Dr. M. Nivian. So we will discuss later on after our session is over.
I want to take up a cataract survey in Karnataka, house to house survey throughout state.
Okay.
That I applied.
Okay, thank you,
Okay.
sir.
I have done it in one district. I have done it in one district 40 years back.
Thank you.
So Dr. M. Nivian
Covering
is the
about
academic
500
director,
villages, house to house.
vitreoretinal surgeon, MN Eye Hospital Private Limited, Chennai. He will be talking on cataract with pre-existing posterior capsular dehiscence. Over to you, doctor.
Thank you, sir. Respected teachers, senior ophthalmologists, my dear friends. So I think it's just right I've come after Sachin because some of the questions asked will be answered in my talk, Abhijit. So I'm going to talk about a case, a phaco case. As you can see here, this was actually a relatively soft cataract and also had a small polar component. So like how the previous discussions are there, I followed all the steps of doing only a hydrodelineation, as you can see, and I wanted to take out only the endonucleus first. Because it was a soft cataract, most of the time it ended up like a bowl, so I just lifted up this endonucleus part, and with the low parameters, you could see everything was going on normally. I was actually trying the carousel technique where you go to the edge of the nucleus and the entire nucleus rolls into it and the endonucleus comes inside. So everything was going on so far so fine, and then suddenly during the last quadrant, see, it opens up there. So I actually frame freezed it and saw, because my second instrument, whether any hit was there. It was not. So then I had to follow all the basic principles of managing a posterior capsular rupture. So the first thing I do is I take the piece, because there's only a small piece that is left. So I wanted to first make sure I'm phacoemulsifying that piece so that I have only the epinucleus plate and the cortex left. The second thing is, don't pull out your probe. So make sure you inject viscoelastic to the left hand, and this doesn't come overnight. So it is better to practice on normal cases with viscoelastics by the time, because you never know in which case you will end up like that. I always prefer the bimanual technique for 2 reasons, where you can separate the irrigation and the aspiration, because I always start from the area of the opposite side of the rupture, because you don't know at this point whether there is actually some amount of vitreous, or during the procedure some amount of the hydro goes in and hydrates the vitreous, and then the vitreous starts prolapsing. So I try to remove as much of the cortex as possible. So starting from the opposite end, stripping the cortex, and then the technique of aspiration also becomes slower. I don't do it fast. I call it something called the cortical stripping. So hold it, strip the cortex, bring it slightly above, and then aspirate it gently. But at the same time, you can see that the rupture is slowly expanding. So I think by the time I finish, there will be some amount of vitreous. Again, following the same thing, before exchanging hands, put in some viscoelastic, plug it, and then exchange the hands. And I was just fortunate enough that I could remove most of the cortex before doing the vitrectomy. So the debate would be that whether you should do a vitrectomy first and then remove the cortex. And the third thing is, I always prefer to stain in any capsular rupture with tricot. And I put the tricot in the anterior chamber. So even though it looks like I put a lot, I wash it away. So once you wash, you can see that the remaining vitreous strands, what it didn't look like vitreous is there, but there are a lot of vitreous strands. So I use the pars plana approach, and slowly, even for anterior segment surgeons, we have the wet labs and everything. So I think the pars plana approach is more ideal in these types of cases when there is a lot of vitreous, for 2 reasons. When you use the pars plana approach, the amount of vitreous you cut from the base is less, and actually it is faster than doing a anterior approach, because when you do through the anterior approach, you're actually pulling more and more vitreous into the anterior chamber, so you don't know when to stop. But when you cut it from the pars plana, from the base, you actually cut the portion, so whatever is on the anterior chamber alone is removed. As you can see here, I'm using the irrigation through the side port and the cutter through the trocar. So, and you can see the stain vitreous. So I always prefer some tricot, and some amount of tricot that goes behind is also useful We have seen the incidence of CME in these types of cases are very, very negligible than what we used to have before. So that is attributed to some amount of the tricot. The other tricot can actually be washed away. It looks like there's a lot of tricot. You can actually wash it away. So once the pars plana vitrectomy is done, all the vitreous from the wounds and the sections has to be cleared, because we all know the rate of endophthalmitis can increase 3-fold times when there is vitreous. So now the challenge here was, because this was a multifocal case, because I saw the previous speakers, they all had 3-piece lenses, because I didn't have a backup 3-piece lens. So the reason here I'm putting the foldable lens in the bag is I could see the edges of my rupture. Because I could save it, it did not extend. So I'm able to see both sides of the edges of my posterior capsular rupture. So went in ahead with my single piece foldable multifocal intraocular lens, making sure that the leading haptic goes into the bag first. Yeah, once the leading haptic is inside the bag, I gently just nug it inside. Don't use the same method like how we do a normal lens. Once you put it, you just dial it inside. So I don't dial it much, just slowly trying to tug in the haptics inside. There you can see. And then some amount of that viscoelastic also can be removed through this pars plana cutter. And I always prefer the Simcoe at the end of the surgery, because in these types of large lens, when you go inside the bimanual, sometimes the eyeball suddenly forms, and I have lost lenses through these large lens also before. So as you can see, this is how it ended. Well-centered multifocal lens with a nice, I think the patient's never going to have a PCO. So sometimes these patients do really well when managed really well. So that was the end of the surgery. This was the slit lamp picture of after 2 weeks. You can see the edges of the rupture and a well-centered multifocal lens with a good Vinci image in the center. And this is the other eye of the patient. So actually the patient was happy with his vision. That's the reason he came back for multifocal for the other eye. So thank you once again. So I'd like to thank All India. And,
so this is the first case, first eye?
Yes, sir.
This is second eye or
the last photo was the second eye. So thanks to Arup sir and Ayan sir for having me in this session.
How many of you would like to put a multifocal in PPC cases? If in PPC cases.
So incidentally last week I had a patient who had operated 6 years back with a restore. At that time I thought it was a PSC. It turned out to be a PSC, and I could put a multifocal. And this time I saw it and I said, I hope it's not a PPC. And it turned out to be a PPC, and I had to put I had to do a similar thing with an anterior optic capture for the same thing. I had to put a panoptics. So I gave it a try.
No, once if the rhexis is intact, then it is not a challenge. Of course, you can always do a good optic capture. But if you don't have an intact rhexis, not a with a PC rent out over there, I think you really need to have guts to put a multifocal.
So Abhijit, do you adjust biometry according to rupture capture? Because
I would
here what you do, you put the IOL in the bag and you capture the optic anteriorly. So the reverse optic capture. So do you adjust the biometry?
I have to ideally, but you have only one lens at a time. I put it, and then I hope and cross my fingers that the other eye is
okay. Going to the this case directly. So Dr. Novin, do you think you started vitrectomy much later? In this particular case, you should have do the vitrectomy much earlier stage of the rent, so that the rent could not extend much more?
That's a very good question, and yes, I think it is a debatable thing. So because the cortex was coming in smoothly, because once you have
it's a temptation or it's a temptation to remove the cortex, because your right side port already the vitreous is coming when you are doing the aspiration.
So you had both the things. So Sachin showed the video where he did the vitrectomy first, and after clearing the vitreous, he removed all the cortex, but he had more of that. But in this, if there was any blockage of the cortex at any stage, I would have definitely stopped. And as you said, do the vitrectomy first, make sure the vitreous is clear, and then go.
So ideally, any vitreous loss, or you should do the vitrectomy, remove the vitreous enough, and then aspiration.
Yes.
But sometimes if you just recognize a PC rent at particular stage and there is no vitreous popping out, you can actually
in this particular case there is a rent, and the lens is enlarged almost
Actually,
Thrice
that's
it's its
that's
size because
that's
of
what
aspiration.
I want to point out is that why the rent actually enlarges. Rent actually enlarges because of the vitreous hydration.
Exactly.
Continuously, when we are doing an irrigation, the vitreous has to hydrate and it has to come out.
Come out.
So instead of using a irrigation port, we do a
Dry
dry
vis-
aspiration,
dry
or we
aspiration.
do what is called as a visco
Visco
aspiration.
aspiration, yes.
Again and again, keep injecting a
Dry
viscoelastic
aspiration.
which holds the vitreous back, and just gently pull off the cortex. You will never have any enlarged PC rate.
So I had just one comment. I think very well managed, and of course, if it's an unexpected situation that but you have no choice to use the existing IOL. But like if it's a posterior polar, especially if the other eye also has had some eventful surgery, then it's maybe a good idea to have a 3-piece multifocal on hand. Also.
3-piece multifocal is really it's a really difficult. It's available. It's available.
No, AMO has withdrawn the 3-piece multifocal.
Techniques multifocal.
Techniques multifocal.
It could be
Multi-piece techniques multifocal.
No, sir, Technis multifocal is also now coming in the single piece only. The 3-piece is not available now.
Okay,
Maybe
okay,
the
okay.
old stock, whatever was there.
It was available.
It was definitely available.
So now we move on to.
There is some, I have already loaded there, but it's not coming
Yeah,
here.
that's the main problem.
So I have a pen drive. So should I put and start?
Pen drive, Sarah's pen drive. Sarah's pen drive. Same thing happened with me.
There.
This presentation was
Can I present from that side?
No, it's not there. It's
So actually,
here.
it's there. So
So
I would like to thank Dr. Bhaumik and Mohanta for the opportunity, and Dr. Partho Biswas. Yes. अरे ये तो एक ही स्लाइड आया है, मेरा प्रेजेंटेशन किधर है? ये प्रेजेंटेशन नहीं है. These are introductory slides. Can we put this and do the presentation? Yeah. Should I put it here? ठीक है ना, मुझे कुछ कॉपी कर. In fact, the presentation was loaded in preview room yesterday itself, and today morning I came here and specially checked whether the videos are running, just to double check. It's okay. We have had interesting videos, so we can maybe we may have a panel discussion sort of thing. We have great vitreoretinal surgeons from Belgaum and Chennai, and great anterior segment surgeon from Mumbai, Dr. Abhijit is there. So maybe you can just.
So our next speaker is Dr. Santosh Bide. He is the president of Maharashtra Ophthalmological Society. He was a past president of POS, past president Maharashtra chapter of IMSICS, secretary trustee POS, secretary Maharashtra chapter of Telemedicine Society of India, consultant Ruby Hall Clinic Pune, phaco and refractive surgeon, and he will be speaking on runaway axis, different situations.
This screen is not moving. I don't know. And the next slide is of Dr. Kavita Rao. Are? This is the. This is what it is showing. Yeah. Either. ये भी नहीं है. ऐसा क्या है? मैंने दिया था ना.
सर आपके नाम से.
संतोष भिड़े है. ये. हाँ यही है ना. करेक्ट. आ गए. यहाँ आ गए. यहाँ आ गए. So good afternoon everybody. At the outset I would like to thank Scientific Committee, Dr. Partho Biswas and Dr. Bhaumik and Dr. Mohanta for giving me opportunity. We don't have any challenging situations during OT also, but we have challenging situations in the conferences as well of loading the PPTs. So the topic given was runaway rexis. I do not have any financial disclosures. Just before starting video, I would like to discuss about mechanics of capsulorhexis, that there are 4 forces which are acting when we are performing capsulorhexis. First is the extrinsic force which we apply, that is a surgical force. The second is the centrifugal force by zonules. Zonules, they keep on pulling the capsule. Third force is there is always egress of viscoelastic from the wound through which we are doing capsulorhexis. And the fourth one is the posterior thrust by the vitreous. Let's see case scenario number 1. This is a intumescent cataract, and I usually prefer to do capsulorhexis with cystitome. As soon as I punctured the anterior capsule, there is a egress of milky fluid which I try to aspirate. Once again, I wanted to make a flap out of that. I'm trying to make the flap, but there is a lot of intralenticular pressure and the rhexis is extending towards the periphery. So I tried to cut it with the scissor and done. It has gone to the periphery. So I try to cut here so that we can at least make a small circular sort of capsulorhexis. Now I would like to ask the panelists running comments. What will you do in such situations? Can anybody take this? So what I did was I cut the anterior capsule here like this, and I was trying to make some sort of semicircular thing on the anterior capsule. I was able to do this on this part. With 26 gauge cystitome, I tried to cut it a small edge so that with the micro forceps, I could hold that edge. I was able to do it. And then gently, I applied a centripetal force and was able to give this. So now I just cleared the anterior chamber from all the liquid, and then with the help of a dialer, 2 dialers, I just rotated the nucleus out of the bag on the ciliary surface. And we all know that Dr. Rohit Om Prakash has already shown videos that whether the rhexis has extended to the periphery or not. So I was sure that this rhexis has not extended to the periphery. So I was sure about doing phaco. So viscoelastic was injected. The nucleus was kept on the just at the plane of the pupillary plane. And then phacoemulsification was performed. With slow motion phacoemulsification, I could remove all the particles. This is the second situation. Again, it is an intumescent cataract. Again, a small nick was given. I'm trying to make a flap out of it, but the intralenticular pressure is so high and the cortical fluid which is there is just not coming into the anterior chamber. I'm trying to aspirate through the cystitome itself, but nothing has happened. So again, I thought of aspirating the cortex, and that has gone to the periphery. So again, it is running away from me. So I think that I have lost the match somehow with cystitome. And I was sure that this rhexis must have gone to the equator, almost to the equator. But for removal of nucleus, you have to enlarge this rhexis. So I enlarged it. and then I resorted to the savior for phacosurgeons, small incision cataract surgery. The tunnels were created. Most important is to create proper scleral pockets so that there is minimal astigmatism and you can remove even the large of the nucleus. With dimple down technique, you have to enter the anterior chamber and the section is opened by dissecting from outside inwards. You can see the capsular flap here. The lens, the 3-piece lens was injected and the lens is there in the bag without any problem. So this was the situation, and at the end of the surgery, we could achieve, we could give a good pseudophakia to the patient. So there are 2 more cases, but I think I am running out of time. So some tips for successful capsular access are: you have to select proper viscoelastic device. One has to regrasp capsular flap while doing capsular access, stay in the plane of anterior capsule. Proper use of shearing and tearing technique while performing capsular access is a must. And if at all there is a rhexis escape, then anterior chamber has to be filled with cohesive viscoelastic. Flap is to be pulled towards the center rather than running after the flap. You just give it a centripetal force. And then if you cannot do it, sometimes you have to cut the flap with the scissors at other end and start a new rhexis from the other end and then join the old one. I would like to thank organizers again for giving me opportunity. Thank you.
So, due to interest of time, we will discuss later on with this about this case. So we now move on to Dr. Santosh Bide. Dr. Piyush Kapoor. He's the director of Healing Touch Eye Center, New Delhi. He's a cataract and refractive surgeon. He will be talking on post-RK cataracts. Over to you, Dr. Piyush.
Thank you, sir, for the opportunity. And I would just begin with my talk and talking about the concerns in RK cases. I would say that in my case, the concerns do not start on the OT table, but they start from the OPD room itself. These patients with RK have high expectations. They already got a surgery done to get rid of the glasses. And they actually come with an expectation that once they get the cataract surgery done, all their issues of glare and halos would disappear and they would actually feel better. So one challenge is like their expectation. The next challenge comes in the IOL power calculation, which probably our patient feels is the easiest job. Usme to koi galti kar hi nahi sakta. So, and we only know that how difficult it is to calculate the IOL power in these patients. Then, of course, the surgical issues, incisions, the quality of vision, the selection of IOL, and of course, the dry eye issues. So to begin with, I would just like to ask the panelists over here that what, sir, do you feel about the IOL power calculation in the RK cases? Should I go on with the talk or any comments? So basically the issue is that all these patients of RK, they have a very flat cornea, and because of the flattening of the cornea, they have issues with the measurement of the IOL power in terms of the corneal power calculation. Now there is an error of 1 diopter of corneal power, which shows an error of about a 1 diopter of IOL power calculation. The second issue comes up with the effective lens positioning. Now, whenever a patient undergoes an RK for a myopia, we'll end up having a very big hyperopic shift in these patients, and the reverse occurs for the hyperopic patients. So there are 3 types of error we generally see. One is the instrument error, the refractive index error, and the formula error. Talking about the instrument error, I would say that most of the instruments measure the central 3 millimeter zone. So we need to look a little more inside into it and also consider the refractive index, which actually changes in these patients. Most of our calculations regularly involve a 1.3375, but in these patients we require a 1.376 on an average. So all this causes almost a 14% change in the IOL power. And thus, it becomes a major biometric challenge that which formula to be used, whether we use an immersion or an optical biometer, which of these formulas actually would work the best. Talking about the present scenario, I would say that nothing but the optical biometer is the choice for these patients. But if you don't have an access to an optical biometer, of course, you can play with an immersion biometry, but the precision cannot be as accurate. When it comes to the formula, the IOL 700 incorporates the Barrett True K TK, which involves the TK, which is the main, which I would say is the best methodology on date to calculate the IOL power for the RK patients. Of course, the ERK with the Holiday 2 combination works very well if we take about of the 4.5 mm zone. The ACRS calculator is available for the ones who are taking a immersion biometry. And of course, if you don't have access to much of the instruments, then going in for the central K to the 1 millimeter and the 2 millimeter zone also gives you a better precision. So talking about the EKR value with the Holiday 2 combination, it is one of the methodology. If you have an access to Pentacam HR, you can actually calculate by taking the 4.5 mm zone value and using the Holiday 2 combination. Of course, the Barrett True K TK with a IOL Master 700 gives us as good or a better precision than this. And the next is the ACRS calculator, which is available free of cost on the website, where you can go back and fill in the values and of course get a good calculation. I have an access to Antrion, which has an Oculix software as well. So this also gives the diagnosis based on the wavefront calculations. And of course, the calculations are not bang on accurate, but they are close to the precision as good as a IOL Master 700. So there is no one particular method available for an IOL power calculation, but there are various combinations available. And one must always choose, like using multiple formulas, multiple instruments, one must choose the highest IOL power you get in these patients. One thing, because these patients have a tendency to go for a hyperopic shit even after the surgery. And second is that generally, whatever calculation you may do, you always land up with a little hyperopia in these patients. Having done all the IOL power calculations, once you are sure with the IOL power, the next challenge goes which IOL to be put, whether a toric, whether a multifocal or a simple monofocal. I would say all said and done, these patients already have a very compromised cornea with lot of abrasions. So my choice always remains going in for a monofocal lens, a zero aspheric one in these, not the negative aspheric ones like the Technis or the Alcon. I generally, as a rule in my clinic, I always use the zero aspheric IOLs in these patients because these corneas are not the normal ones. And always specify that there is a need of glass post-operative to the patients. Never ever, over-promise these patients that you will be totally spectacle-free. After having moved on to the OR room, the first step is the wound construction, of course. The wound construction, mostly in these cases, we prefer doing a scleral tunnel. I always do a scleral tunnel in these because this is the methodology which would never open up the radial cuts. The moment you are going in through the corneal tunnel, you would see that the radial cuts get stretched out and gradually they will give way, which would need to be sutured later and give rise to astigmatism, of course a leaky wound, and the surgery goes all messy. Of course, when there are very small cuts, like there are 4 cuts or 6 cuts, if you have a sufficient gap between the cuts, one can go in for a corneal incision as such, not bothering to go in for a scleral tunnel in these cases. So next is the capsular axis. When it goes, generally there is a tendency that these patients have a very deep AC. So you always must have a cystotome with a longer needle length so that you can reach up to the anterior capsule comfortably and tend to make as big a axis as possible, though it should not be too big to cause the nuclear prolapse, but it always should err towards the bigger side. Phaco would always require a less turbulence in the chamber, so the parameters are kept low so that there is less tension on the incisions of the cornea. As you see, this is also a moderate cataract. I would just move fast on it. Going in with the incision, with irrigation and aspiration, I generally prefer a bimanual technique and prefer to go between the two cuts. And then going ahead with the IOL insertion, loading a zero aspheric lens. And to summarize, I would say best in biometry, of course, is the Barrett True-K TK. Monofocals are the best lens to be chosen. Torics may be planned in a fairly regular cornea with less cuts. Scleral tunnel is the always preferred way of dealing with these patients. And less turbulence phaco is the way to go with a minimum wound hydration, which is the next thing I would like to specify, that when you tend to just hydrate your wound too much, then also the incisions open up and the astigmatism actually changes. So I do a very minimal wound hydration, but at the same time, you need to be sure of the wound construction, that they are those real self-sealing ones. Thank you.
Thank you. Thank you, Dr. Piyush.
The wound hydration, it is actually limited to the next section.
Yes.
So never it is complete. It's if you any idea put on suture is better, because wound hydration is never good in cases of.
I generally leave the wound even minimally hydrated, because if I see that, I have seen with my experience that if you are giving a very good wound construction, even if your chamber is flat and you just bandage the patient and open the iPad next day, you will find a proper wound and a well self-sealed one. So the minimal wound construction, and I actually fear that there is kind of an epithelial migration once you just leave the sutures open after a wound hydration, which gives a kind of a permanent change in the astigmatism and makes the things worse actually for the patient.
So it's a really comprehensive talk regarding the RK cataract surgeon RK, starting from biometry evaluation. I think today's scenario, ray tracing probably would be the better, but still Olson, we are waiting for the final result of Olson ray tracing. Oculis is a Barrett True-K TK is a much better formula so far. Even some surgeons says EKR Holiday 2 is better for this, but it's easily available.
The precision is such that the Barrett True-K TK is almost up to about a 0.5 precision, but EKR would be somewhere about a 0.75 or so.
So it is even much better than ACRS formula.
That is the gold standard.
So it is now recommended to use Barrett True-K TK. So
that you're talking for IOL
Master 700 only.
Now suppose you don't have the IOL Master 700, how do
ACRS IOL calculator I think is a better option in those cases. So ACRS IOL calculator.
I would even say the scenario with a basic clinic even. Like if you have an access to maybe a topographer.
Even if you don't True-K TK, it's a Barrett True-K. Only True-K is a better than any other form.
So the True-K also has an option of entering the posterior corneal curvatures manually.
Exactly.
So you would go for the central 3 millimeters or the central 5 millimeters?
I think 3.
No, I think you should always aim for rather 2 to 2.5 millimeters. It should be like in my clinic, in the days when I have been, when this True-K and all were not available, I used to actually see the 1 millimeter, the 2 millimeter, the 3 millimeter, and I used to make a calculation with all the K values, and the one which I used to get the highest, I used to choose that. So the main thing is that you need to go bang on the central one and always choose the highest IOL power you get.
Highest even keep it as a slightly myopic, as Abhijit said, if it is 2K, TK not available, Barrett 2K with slightly myopic is the answer today's scenario. It's a very good formula. So probably in future also ray tracing will be the formula for this type of cases. Thank you so much for the all panelists and speakers in this session. We are call it a end, and I think our time is over.
We are running very much short of time. I mean, we have already.
Thank you, Abhijit, Dr.
Kavita
and Dr. Kapoor. Thank you so much, Dr. Sachin.
I can see Dr. Rajendra Prasad already waiting for the next session.